come and join the course. So the first topic that we will be starting with today is on tachyarrhythmias, approach and management of atrial fibrillation. So just to make one thing clear, this is not going to be like a routine seminars or the discussions that happens during the conferences. What we are planning to do is exclusively just concentrate on exam-oriented discussions. That is, whatever is needed for your theory exam alone will be emphasized and discussed so that there would not be too much of stress of a lot of topics on your head. So with regard to tachyarrhythmias, there will be four important areas that I will be covering. One is about the etiology, the pathophysiology, the approach to the diagnosis, and the treatment. So any of these four can be asked as a question. So usually they can break it up into three parts like pathogenesis, approach to diagnosis, and treatment. Or they may combine it with another topic like atrial fibrillation management, and they may put it for a total of 10 marks. So you need to know about it as a whole, but like I said, we don't need to know about it in depth. There are only certain things which you need to concentrate, and that is what I'm going to emphasize on. So we'll go into the topic proper. If you have any queries, please do ask towards the end of the session. You can put it in the chat box, or if you want to ask it at a later time, please be free to message us in the WhatsApp group. So we will definitely help you out with the queries that you have. So first come into the tachyarrhythmias part. So like I said, we will be covering it under four areas: etiology, pathophysiology, approach to diagnosis, and treatment. So coming to the etiology, so as you know, tachyarrhythmias have a wide distribution. It can be sinus tachycardia, or it can go on to ventricular tachycardias. So it can have a wide spectrum. So if you see the etiologies, invariably it will fit into one of these. So you need to have an idea of how to approach. So the most common causes of tachyarrhythmias usually are pain, anxiety, or agitation, and delirium. It is bad. Then if there is presence of organ ischemias in the form of myocardial ischemia due to a coronary thrombus, or possible respiratory failure because of hypoxia, heart failure, acute heart failure especially, acute kidney injury, whereby if acidosis is present, that itself can cause tachyarrhythmias. Or if there is hyperkalemia, that can cause also tachyarrhythmias. And if there is presence of acute liver failure because of the thirst response. And if there is presence of a malignancy, that is an active malignancy with active manifestations that are occurring in the form of DAC or any other form of thrombosis. Then the next factors that you need to keep in mind are medications. The most common are anticholinergics, beta receptor agonists, chemotherapeutics, inotropes, and vasopressors. So one thing I want you all to keep in mind is inotropes and vasopressors are different. Inotrope is to improve cardiac contractility, and vasopressors is to improve the peripheral vasoconstriction. SIRS related, post cardiac surgery, trauma, burns, sepsis, or hypothermia syndromes. That can be malignant hypothermia or serotonin syndrome. Then homeostasis impairment, like there can be severe dyslipidemias. The most commonly associated is with hypokalemia or presence of hypovolemia, which can be absolute due to hemorrhage or relative as a form of sepsis. Presence of anemia or acidosis. hormonal in the form of hypothyroidism, and intoxications that can be either toxins or withdrawals. So the most common implicated etiologies are alcohols, cocaine, and other sympathomimetics like methamphetamines. And in addition to the above, various forms of shock: hemorrhagic, distributive, cardiogenic, or obstructive. Obstructive in the form of pulmonary embolism, tension, pneumothorax, or a cardiac tamponade. So if you look into the etiology for tachyarrhythmias under these headings, 90% of the time you would not miss anything. So another possible way of looking into it is you look at pain, agitation, and delirium as the first possible etiology, and then look at the 5 H's and 5 T's. Because all of the 5 H's and 5 T's in the initial phase can cause arrhythmias, either brady or tachyarrhythmias. So you can look into that. And along with that, you can look at the other causes that I mentioned above. So in that way, you would have a better clarity. And especially when you're going to give your practical exams and when they ask you the approach in your ECG station, this will be help you in a big way. So we've completed the etiology. The next is about the pathophysiology. So why do tachyarrhythmias occur? So there are three implicated mechanisms. One is enhanced automaticity. Second is reentrant arrhythmias or reentry. And the third one is triggered arrhythmias, which can be further divided into early after depolarizations and late after depolarizations. So these are the three important pathophysiological mechanisms that cause tachyarrhythmias. So these three need to be known because in the exam, pathophysiology in related to tachyarrhythmias has been asked. So you need to know about it. So we'll go one by one. The first thing is about the basics that we need to know. So you need to know about the pacemaker action potential. So the first phase is the phase 4, as we can see here. So here the ion channels open that conduct the slow inward depolarizing sodium currents. Okay, so this sodium currents that will be at the base, at the more negative side, are called the funny currents. So once these channels start to open, these will cause a spontaneous depolarization initiating the phase 4. So that is what occurs first. So as the membrane potential starts to go into the positive side, that is towards -50 and -40, during this phase, the calcium channels start to open. All right. So the phase 4 part is where there is going to be opening of your sodium currents or the funny currents. These currents usually open automatically. So in response to the membrane potential. So once it reaches a certain threshold, around 40 to 50 millivolts, then the calcium channels open. So that's when your phase 0 occurs. So once it comes to just above 0 millivolts action potential, the phase 3 begins, whereby potassium channels start to open and the calcium influx stops. That is, the calcium channels close. So this is the phase where the next phase occurs. That is the phase 3 or the hyperpolarization phase. So as the membrane potential comes more negative towards -60 to -70, the sodium currents are again stimulated, whereby the next cycle is then triggered. So this is about the pacemaker action potential. So phase 4 is about the funny currents being activated. Phase 0 is the calcium channels being opened, and phase 3 is the potassium channel getting opened and the calcium channels closing. So this concept is necessary because enhanced automaticity is based on this pacemaker action potential. So enhanced automaticity is usually seen in ventricular tachycardias and atrial tachycardias. So this is mainly in relation to the action pacemaker potential. So what is automaticity? It is basically defined as spontaneous depolarization occurring during phase 4 of the action potential. Like I said, when the funny currents, that is, there is sodium influx occurring, that will start to trigger the pacemaker potential, and this process occurs automatically. The important thing to note is that this is highly regulated by the autonomic nervous system. So, as you all know, the autonomic nervous system has two parts, that is the parasympathetic and the sympathetic. So, how does the parasympathetic nervous system influence your heart rate? So, these are the basic steps. First, there will be local acetylcholine release. So, that will cause stimulation of your muscarinic potassium channels. So, because of this, there will be increased potassium efflux, leading to hyperpolarization. Because of this hyperpolarization that is occurring, there will be slowing of your phase 4 depolarization, and that will lead to a decrease in your heart rate. So this is how the parasympathetic nervous system influences your chronotropy. Whereas sympathetic nervous system does the exact opposite, but through different receptor. So what happens here is there will be stimulation of your beta-1 receptors. So there will be increased depolarization of your L-type calcium channels. So there is going to be increased calcium influx, leading to increased depolarization, increased atomicity, and that will lead to an increase in heart rate, increasing your chronotropy. So this is the basic mechanisms how the autonomic nervous system plays a role in your chronotropy. So if there is going to be an intense parasympathetic nervous system activity, like following organophosphorus compound intoxication or any form of neurotrauma, then there can be a severe parasympathetic stimulation that can cause the negative chronotropy. Whereas with sympathetic nervous system, any form of sympathetic stimulation, be it drugs or any form of surge response, pancreatitis, burns, sepsis, can lead to this increased chronotropy through this mechanism. So the next pathophysiological mechanism is about re-entry. So this is mainly seen and commonly seen with SVTs, with supraventricular tachycardia in the form of AV and RP, AV nodal re-entering tachycardias, atrial flutter, WPW syndrome, or SCAR-VT. So it is basically defined as a continuous repetitive propagation of an excitatory wave. All right. Continuous repetitive propagation of an excitatory wave traveling in a circular path. All right. And then it returns to the site of origin to reactivate that site, leading to tachyarrhythmias. So I'll just repeat it once again. Reentrant tachyarrhythmias are defined as continuous repetitive propagation of an excitatory wave traveling in a circular path and then returning to its site of origin to reactivate that site. So if you understand this definition, the subsequent mechanism of it would be more clear. Because you would have seen this diagram a couple of times in Harrison. So the concepts of it usually was a little difficult to understand, but when you look into the in-depth content of it, it is very easy. So as you can see here, this is about the re-entrant mechanism, as you can see. So most of you would have seen this diagram, but the concept of it is what I want to emphasize it. And I made it as simple as possible so that it creates a very good understanding. So the requisites for this re-entrant tachycardia to occur are: one, there should be failure of group of fibers to activate during the depolarization wave. That can be due to anatomical obstacle or a functional obstacle. Anatomical may be following a myocardial infarction, where there can be myocardial scarring. And functional obstruction can be because of various causes. electrolytic balance, hormonal issues, so on and so forth. So as you can see here, we can see a kind of lot of crooked zigzag lines. So this area is the failure of conduction area. So here there is an issue with the conduction, and this is the normal side. So this is the first prerequisite that needs to be satisfied. Second, adjacent tissues and pathways must have different electrophysiological properties and joined proximally and distally forming a circuit. All right, so this is the second one. So here you can see this half semi-circle pathway has a different property, and this one will have a different property. So here, if you can see, this is called the slow pathway, and this is called the fast pathway. So there will be two pathways of totally different electrophysiological properties, and they will be joined together proximally and distally, forming a circuit. So this is about requisite 2. Requisite 3 is there should be transient or permanent unidirectional block of one pathway, which is a must. So as you can see here, the zigzag lines over here, that is the slow pathway, is affected. So this should be there for the re-entrant tachycardia to occur. And each involved pathway can conduct impulses in an antigrade or retrograde fashion. So this is obvious, because if this is there only, there can be a re-entrant tachycardia occurring. All right, so these are the 4 things. Failure of group of fibers to activate during depolarization wave. Adjacent tissue or pathways must have different electrophysiological properties, and they should be joined proximally and distally, forming a circuit. There should be transient or permanent unidirectional block of one pathway, and each involved pathway can conduct impulses in an antigrade or a retrograde fashion. All right. So coming to the mechanism, there are normally 2 functional pathways. Like I said, there is a slow pathway or a slow conduction pathway or alpha pathway. And there is a fast conduction pathway or a beta pathway. So as the name itself says, because it is fast conduction, the impulses are conducted fast through this circuit and slow through this. All right. And the other important thing is, in the slow pathway, it will have a short effective refractory period. Now, this is a very, very important terminology that needs to be understood. All right. So what is effective refractory period? So it is nothing but the time during which the cardiac cell is unable to respond to a new stimulus. All right. Regardless of its strength due to the ongoing repolarization. So I'll just repeat it once more for better clarity. It is the time during which the cardiac cell is unable to respond to a new stimulus, regardless of its strength due to a ongoing repolarization that is occurring. All right. So if there is a short effective refractory period, then the next impulse can be generated, and that will be able to stimulate the heart again. Whereas if a long refractory period is there, that will take more time for the heart to get stimulated by a newer response. All right. So if the slow conduction pathway is affected, that is going to be a big problem, because it has only a short effective refractory period. So once the area is affected and it has only a short effective period, this area, once the effective refractive period is over, the re-entrant fast pathway, electrical pathway that is going through this impulses, the impulses that are going through this fast pathway will reach the ventricles, again come back, and since this refractive period is over, it will again go through this route and again stimulate your SA nodes or AV nodes, and that can trigger new arrhythmias. I hope I made it clear. Anyway, I'll again explain it with the pure flow charts. So in sinus rhythm, atrial impulses conduct via the fast pathway. This is normal physiology. If an atrial impulse occurs prematurely via the fast pathway while it is refractory, it then enters the slow pathway. All right. So because this has a longer effective refractory period, any new stimulus that occurs is not going to pass through this because of the long effective refractory period. It is like a gate which is shut, which does not allow any movement of impulses. So once the impulse is propagated to the ventricle, it travels back to the fast pathway, which has now become excitable in a loop pattern, and that can initiate re-entry tachycardia. All right. So I'll just, for revision's sake, I'll just say it again. Thing is, the slow pathway being affected has a short effective refractory period. Meaning to say, from the SA node, if you have an impulse that is coming through the AV into the bundle, if this area is affected, the predominant impulses are going to pass only through your fast pathway. All right. So through the fast pathway, it is going into the ventricles and it is going to produce an impulse. Then again, it will bounce backwards and try to go into your fast pathway. But because this has a long effective refractive period, it cannot go through this route. And since this area is affected, the impulses cannot pass through this way. So what happens is, this having a short effective refractory period has now become excitable. So what happens is, the impulses which had gone to the ventricle, that from the fast pathway, again come back, then go into the slow pathway and enter back into the nodal areas where it again stimulates them, and that itself can lead to arrhythmias. So I hope you all have understood this concept, because this is what actually happens in atrial flutter and AV and RP. So the next one is about triggered arrhythmias. So triggered arrhythmias occurs in relation to the cardiomyocyte action potential. The first two, which I had spoken, automaticity and reentrant tachycardias, are all related to the pacemaker potential, whereas triggered arrhythmias are in relation to the cardiomyocyte action potential. So it is defined as abnormal depolarization occurring in the late phase of the action potential in the cardiomyocyte, leading to sustained arrhythmias. So what you can see here in pink is the normal cardiac action potential. So this, as you all know, is phase 0, where there will be sodium influx. Then here will be phase 1, this small area. This is phase 1, where the sodium channels close and the potassium channels open. And this plateau phase is phase 2, where there will be calcium channel influx with potassium channels also being open. And here is phase 3. Phase 3 is where calcium channels close and the potassium channels remain open. And phase 4 is where the sodium potassium ATPase pump is activated, thereby causing a change in effluxes between the sodium channels and potassium channels. Meaning to say, potassium is moved back into the cell and sodium is moved out of the cell. So, like I said, under triggered arrhythmias, there are two types. One is early after depolarizations, or EADs. So this typically occurs during the phase 2 to phase 3 of the action potential. That is when the calcium channels open and when the calcium channels close. So this is seen during Passadade pointers in long QT syndromes, and they also can manifest as premature ventricular contractions. So the important thing to highlight here is, the VPCs that we normally talk about are mainly due to this early after depolarizations. And delayed after depolarizations occurs during phase 4 of the action potential. Example, VT associated with digitalis toxicity or reperfusion related VPCs or VT that can occur following either percutaneous coronary interventions or post CABG. or when they're being from the bypass pump. In any of these circumstances, DIDs can occur. So, as I said, there are three important pathophysiological mechanisms to be kept in mind: automaticity, re-entrant tachycardias or re-entry mechanism, and triggered arrhythmias. In this, automaticity is purely dependent on the autonomic nervous system activity. So, parasympathetic and sympathetic is that any kind of impairment or overactivity of your either systems can lead to changes in your automaticity. With regard to enhanced automaticity, like I said, in regard to tachyarrhythmias, either if there is a decrease in your parasympathetic nervous system activity or there is an increase in your sympathetic nervous system activity, that can lead to an enhanced automaticity. All right. Then, with regard to re-entrant tachyarrhythmias, the important thing is to know about the fast pathway and the slow pathway. The slow pathway has a shorter effective refractive period, and the fast pathway has a longer effective refractive period. So, because of this, when there is an impulse conducted from the nodes till the bundles, there is going to be a continuous loop which occurs because one of the pathway is non-functional. And at the same time, it has a short refractive period, making it excitable. So because of that, there will be a continuous loop which occurs within the circuit, and that itself can go and trigger the nodes and lead to arrhythmias. So the most common arrhythmias that are implicated are AVNRP, atrial flutter, and WPW, that is Wolff-Parkinson-White syndrome. Then coming to triggered arrhythmias, there can be two types. One is early after depolarizations and delayed after depolarizations. Early after depolarizations is usually seen in phase 2 and phase 3 of the cardiomyocyte action potential, and delayed after depolarization is usually seen in phase 4. All right. So this is about the pathophysiology. And the etiology is, as I had told, you need to know about the 5 H's and the 5 T's in addition to pain, agitation, and delirium. And then you look at the other possible factors that I had discussed. So that way you will have a comprehensive understanding. So if you are able to mention all these in the form of flowcharts and diagrams, that is more than sufficient rather than writing paragraphs in your theory. So next is about the approach to diagnosis. So first, we will look into the narrow QRS complex, and then we look at the wide QRS complex. With regard to the narrow QRS complex, you have regular and irregular. So irregular is pretty straightforward. You can have 3 possible DDs. One is atrial fibrillation, atrial flutter with variable AV block, and multifocal atrial tachycardia. Whereas in regard to the regular, we need to see if P wave is invisible. If it is invisible, then AVNRT would be your first probable differential in mind. Whereas if the P wave is visible, then you need to evaluate it further. So you need to look at the P and the QRS ratio. So if the P and QRS ratio is more than 1, then it can be either an atrial flutter or an atrial tachycardia. Whereas if the P wave and the QRS is equal, that is there is P wave and QRS, P wave and QRS. In that kind of a format, then you need to check into the RP interval. All right. So if the RP interval is short, that is less than 70 milliseconds, then it is high likely going to be an AVNRT. Whereas if it is long, more than 70 seconds, then it is likely to be an atrial tachycardia or sinus tachycardia. So this is one of the easiest ways of identifying a etiology, identifying the type of tachyarrhythmia with a narrow QRS complex. So irregular is straightforward. For regular, you check the P wave, if it is visible or not. If it is not visible, AV and RT. If it is visible, then you check the P is to QRS. If P is to QRS is more than 1, then it is atrial flutter or atrial tachycardia. Whereas if P and QRS is equal to 1, then you check the RP. If RP interval is short, less than 70, then it is AV and RT. If it is long, more than 70 milliseconds, then it is either atrial or sinus tachycardia. Then the differentials for wide QRS complexes. So wide QRS complexes are QRS complex more than 120 milliseconds. So here also you have regular and irregular. With regard to irregular, it can be because of atrial flutter with WPW syndrome or atrial fibrillation with WPW syndrome, atrial fibrillation with bundle branch block, or atrial flutter with variable AV block. So either of the three can be there. Then if it is regular, you need to check if there is AV dissociation. If there is no AV dissociation, then you check the QRS morphology. If there is a typical LBBB or an RBBB kind of a picture, then it is probably a SVT. Whereas if it is going to be an atypical bundle branch block, then it is going to be a probable VT, ventricular tachycardia. Whereas if it is a broad complex QRS, which is regular, and there is presence of an AV dissociation present, then it is going to be a VT. Whereas if there is no AV dissociation present and it is regular, then it is going to be an atrial flutter. So this is how we usually classify the type of tachyarrhythmias. So just for revision purpose, under irregular broad complex QRS, you can have an atrial fibrillation in WPW syndrome, atrial fibrillation with bundle branch block, or atrial flutter with variable AV block. So these three differentials are to be kept in mind. Whereas if it is regular, you need to check if the AV dissociation is present or not. If it is not present, you check the new QRS morphology. If there is typical LBBB or RBBB, then it is likely to be an SVT. If it is atypical, then it is probably a VT. If there is AV dissociation present, then it is invariably a ventricular tachycardia. Whereas if it is not, then it is likely to be a atrial flutter. So this is the way to approach. So the next part of it is management. So this is from the AHA guidelines. So most of you would be definitely familiar with this. This is just for revision purposes. So assess the appropriateness of the clinical condition and see if the heart rate is more than 150 beats per minute. So the next thing is you identify and treat the underlying cause. Meanwhile, the first thing you need to do is maintain the patent airway, assess breathing as necessary. Oxygen if the patient is hypoxemic. Cardiac monitor to identify the rhythm, plus monitor the blood pressure and the saturation. And an IV access should be placed if it is not. Most patients in ICU would definitely have an IV line, so that would not be very concerning. And a 12-lead ECG is also crucial. So if there is persistent tachyarrhythmia that is causing hypotension, hypermental status, chest pain, signs of shock or acute heart failure, if any of this is present, then you need to go with synchronized cardioversion. So if synchronized cardioversion is to be done, you always need to consider sedation. Airway equipments need to be kept ready as standby. And if it is regular narrow complex, consider adenosine. So the first dose is 6 milligram rapid IV push followed with NS flush. And the second dose is 12 milligram if required. And if it is refractory, despite your cardioversion, then you need to immediately look into the underlying cause, need to increase the energy level for the next cardioversion, consider addition of an antiarrhythmic drug, and take an expert consultation. So the synchronized cardioversion dosing for a narrow regular, like an AV and RT, 50 to 100 joules biphasic would be sufficient. If it is narrow irregular, like atrial fibrillation, we need to give it at 120 to 200. If it is wide regular, like ventricular monomorphic ventricular tachycardias, then you will go with 100 joules. And if it is wide irregular, polymorphic VT, or there is possible in those kind of situations, PVTs, then you need to go at defibrillatory doses and you do not need to synchronize it. Whereas if these 5 features are not there, the next thing is you need to assess if the QRS is wide or not. If the QRS is not wide, then it is an narrow complex tachyarrhythmia. Then you can attempt for vagal maneuvers if it is regular. You can consider adenosine if it is regular. Beta blockers or calcium channel blockers are the mainstay of treatment, and an expert consultation should be taken. Whereas if the QRS is wide, that is more than 0.12 seconds, then you need to consider adenosine only if it is regular and monomorphic, and antiarrhythmic infusion should be initiated at the earliest. Either you could go with amiodarone, procainamide, or sotalol. So for amiodarone, the first dose is 150 milligrams over 10 minutes, and repeat as needed if VT recurs. And the follow-up maintenance infusion of 1 milligram per minute for the first 6 hours. Whereas for sotalol, it is 100 milligrams over 5 minutes. And the important thing is you need to avoid it if there is prolonged QT. And for procainamide, you need to give it at 20 to 50 milligrams per minute until the arrhythmias is suppressed or if there is any hypertension that develops. And it needs to be avoided if there is prolonged QT or there are signs of congestive heart failure. The maintenance infusion after this first dose of 20 to 50 milligrams per minute that is given is 1 to 4 milligrams per minute. All right. So, despite your medical interventions, if it is still refractory, you need to consider the underlying cause. Then you need to consider addition of an antiarrhythmic drug and take an expert consultation. So this is about the tachyarrhythmias. So the next area we will be covering is about atrial fibrillation. So atrial fibrillation was asked in the within the last 2 years. They had asked about the treatment and the diagnosis. So both of them were asked. So it is important to know about it as a whole because in exams, theory or practicals, atrial fibrillation is very, very important. In ECG station, definitely atrial fibrillation ECGs will be kept and questions in relation to that will be definitely asked. So you need to know about it and you also need to know about the Chadwick score and the Hazlitt score, which I will definitely talk about subsequently. So coming to atrial fibrillation, the definition is it is a supraventricular tachycardia with uncoordinated atrial electrical activation and consequent ineffective atrial contraction. So the ECG characteristics are irregularly irregular RR intervals and absence of distinct repeating P waves. So the risk factors for atrial fibrillation are hypertension, diabetes, obesity, overweight, COPD, OSA, CKD, smoking, alcohol, or valvular heart diseases. So any patients in this kind of a background are very much prone to develop atrial fibrillation. And along with this, if it is a new onset AF in ICU, presence of sepsis itself is supposed to be a risk factor. So for symptom severity assessment, you have something called the ERA scale, that is EHRA scale, which has 4 gradings. One is no symptoms, 2 is moderate symptoms, that is normal daily activities is unrestricted, 2 is severe, whereby normal daily activities is restricted, and 4 is massive or disabling. Normal daily activities is not possible. And the most important thing is about classification, because invariably examiners love to ask these questions. So you need to know about it. The first is about what is a paroxysmal AF. So it is one that terminates spontaneously or within 7 days of onset. So the exact numbers need to be kept in mind, because paroxysmal means sudden. So what we would be thinking is, okay, suddenly it gets reverted. But as per the ESC guidelines, they specifically say it terminates spontaneously or within 7 days of onset. So that needs to be kept in mind. Then persistent. AF sustained beyond 7 days, including episodes terminated by cardioversion, which may be either electrical or pharmacological. Or permanent. AF that is accepted by the patient and by the physician. That is only called a permanent AF. And long-standing persistent is a continuous AF of more than 12 months duration when decided to adopt a rate control state. So diagnostic workup for an AF is, you need to look at the complete blood counts. You need to look at the serum electrolytes. You need to look at the thyroid function test and the renal function test. You need to look at the echocardiography. And if the patient has presented with a stroke, in the background of an atrial fibrillation, you need to do a neuroimaging. So these are all vital investigations that need to be done in this cases. So coming to the management, there is something called the ABC pathway. So this is one thing which you need to keep in mind. So ABC pathway is nothing. A stands for anticoagulation or avoid stroke. B is better symptom control. And C is comorbidities and cardiovascular risk factors. What is crucial to us is the first two, that is anticoagulation and stroke prevention. The second one, that is rate control and rhythm control. All right. So the first one is about anticoagulation to prevent stroke. So this is based on the Chadwas score. All right. So the maximum score is 9. So if the score is 1 in males or 2 in females, you need to consider stroke prevention with oral anticoagulants. This is supposed to be a class 2A recommendation. Whereas if it is 2 or more or 3 or more, then oral anticoagulation is recommended. That is class 1A. All right. So that is the most important thing that you need to keep in mind. So once you have decided about starting oral anticoagulation, the next is about assessing the risk of bleeding. All right. So for that, you need to assess the Has-Blood score also simultaneously. So you do the scoring and you assess and find the score less than 3, then it is a low risk of bleed. So what is the significance of it? You need to follow up the patient every 4 to 6 months. That would be sufficient. Whereas if the score is more than 3, you need to have a more aggressive surveillance. That is, you need to follow up the patients every 4 weeks. So that is the clinical importance of the score. So the oral anticoagulants that have been approved for use, you have Dabi, Incatrin, Rivaroxaban, Apixaban, and Edoxaban. So there is a standard dose and a reduced dose. Okay. So the standard dose for Dabi is 150 milligrams BD. Rivaroxaban is 20 milligrams OD. Apixaban is 5 milligrams BD. And Edoxaban is 60 milligrams OD. There will be certain situations where you need to give a reduced dose. All right. So I mentioned that as the third point. The dose reduction criteria for dabigatran is if at all you are going to use verapamil concomitantly, if the patient's age is more than 80 years or there is an increased bleeding risk. In these scenarios, you need to give a reduced dose, and that dose is 110 milligrams BD. Whereas if for rivaroxaban, if the creatinine clearance is on the lower side, that is between 15 to 49, then you need to give it plus 15 milligrams OD. For apixaban, if the age is more than 80 the creatinine is more than 1.5 or the body weight is less than 60 kgs, then you need to give it at 2.5 BD. Whereas for edoxaban, if the creatinine clearance is between 30 to 50 or body weight is less than 60 kgs, you need to give it at 30. Now, the most easiest way of remembering this is in the exam, definitely it's very difficult to remember the numbers. For rivaroxaban, apixaban, and oxaban, if there is renal dysfunction, you immediately need to give it at a lower dose. That is pretty straightforward. Because for edoxaban, they say 30 to 50, apixaban, they say creatinine more than 1.5, and rivaroxaban is 15 to 49. So invariably, if there is renal dysfunction, then we need to give it as a dose reduction. And for apixaban and edoxaban, you have weight considerations. Whereas in rivaroxaban, weight consideration is not there. And for DABI and apixaban, you have age limit. So if age is more than 80, you need to give it at a reduced dose. So these are the important things you need to keep in mind. So for 10A inhibitors, renal clearance is affected. So you need to give a dose reduction. Weight considerations has to be taken for apixaban and edoxaban. And for dabigatran and apixaban, age factor also needs to be kept in mind. So these are the three things which need to be looked into before giving a reduced dose. So the next thing I wanted to comment is about the CHAD-VASc and the Has blood score. So for the CHAD-VASc, the factors you need to look is evidence of congestive heart failure or LVEF less than 40%. That will be score 1. Presence of hypertension is score 1. Age more than or equal to 75, score 2. Presence of diabetes is score 1. Stroke, transient ischemic attack or thromboembolism takes a score of 2. Presence of vascular disease is score of 1. If the age is between 65 to 74, the score is 1. And if patient is a female sex, the score is 1. So this is about the CHAD-VASc score. All right. So from a theory perspective, please memorize this score. It will be asked, and the cutoffs which I had mentioned previously, score of 2 or more in males and 3 or more in females. That is like the cutoff for initiating OACs, that is oral anticoagulants. All right. And for Has blood criteria, each letter has a meaning. So H is hypertension, A is abnormal renal or liver functions. So it can, if both are present, the score is 2. Any one is present, the score is 1. Then S is stroke, B is bleeding, L is labile INR, E is elderly, age more than 65, and D is drugs or alcohol. So if any of all these are there, you ultimately need to check the score if it is 3 or more than 3, less than 3 or more than 3. So based on that, the bleeding risk can be estimated, and that will determine the importance of reviewing the patient. So the first part of it we have discussed, that is anticoagulation to prevent stroke. So the next one is about better symptom control. So the important thing is in AF, you need to get the rate less than 110. And with rate control, you should also get good symptomatic improvement. So that is supposed to be one of the success in management of your patient with atrial fibrillation. So the drug of choice for rate control. If the patient has hypertension or the patient has history of heart failure with preserved ejection fraction, the first line drug is to go with a beta blocker or a non-dihydropyridine calcium channel blocker, either diltiazem or verapamil. Whereas the second line is you can consider digoxin or beta blocker or a non-dihydropyridine CCB. So in first line, you've used a beta blocker. Second line, you can use digoxin or the other two, if at all it is not used in the first one. Whereas if the patient has heart failure and the patient does not have any active signs of failure at that point of time, the first line you need to go with this with a beta blocker. And the second is to go with either digoxin or amiodarone. Please do not use CCBs because already it is a failed heart. Dihydropyridine, non-dihydropyridine CCBs will further compromise the LV function. And in patients with severe COPD or asthma, the first line is to go with diltiazem or verapamil, and the second line is digoxin. So third line can be a combination of three drugs, plus you need to further evaluate for possibility of cardiac resynchronization, plus or minus AV nodal ablation. So this is about the process of how we go about rate control. So then coming to rhythm control. So it is mainly indicated in symptomatic patients with atrial fibrillation. So who are those symptomatic patients in our ICU? So if you had seen the tachyarrhythmia protocol, if there is presence of hypotension, acute altered mental status, signs of shock, ischemic chest discomfort, or acute heart failure, those kind of patients, set of patients are the ones who are coming under this category. So you assess if they are hemodynamically unstable. If they are hemodynamically unstable, then you need to go with electrical cardioversion in these subset of patients whom I just spoken about. So for atrial fibrillation, the dose you need to give is 120 to 200 joules as a biphasic. Whereas if the patient is hemodynamically stable, that is, there is just an AF going on, but there is no other cardiac symptoms or any cardiac signs that are evolving, then you can go with further assessment. You assess if there is presence of structural heart disease. That is, there is any remodeling that is present. If it is there, then you need to assess if there is heart failure, which is in the grade of 2 to 4. If it is there, then you need to go with amiodarone. If no, then you can go with varnacalant. The thing is, it is not available in India. Whereas if there is no structural heart disease, then you can attempt flecainide, propafenone, or ibutylide. But in most of our setups, we either go with amiodarone, and if amiodarone is contraindicated, in most of the settings, we go with ibutylide. But ibutylide needs to be used very much with caution because that drug can itself lead to sudden cardiac arrest. So it has to be very carefully used, and strict monitoring is essential. So as I said, the better control, we have rate control and rhythm control. Rate control, there are three, you can split it into three parts. Patients with hypertension or heart failure, without ejection fraction, then patients with reduced ejection fraction, and then patients with severe COPD or asthma. So based on that, you can select your medication of choice. And the third line of therapy, you can combine 2 to 3 medications. And along with that, you need to consider cardiac resynchronization therapy plus or minus AV nodal ablation therapy. Whereas if the patient is having symptomatic AF, then you need to see if this patient is stable or not. If it is unstable, you cardiovert. If the patient is stable, then you see if there is structural lesions. If the structural lesions is there, you check the grade of heart failure. If it is 2 to 4, you go with amiodarone. If it is 1, then you go with varnacalant. Whereas if there is no structural heart failure, then you can consider propafenone, flecainide, or ibutylide. So the last part of that pathway, that is the C, includes comorbidities and cardiovascular risk factors. So lifestyle changes, that is obesity reduction, regular exercises, reduction of alcohol use, etc. So these are the pharmacological rate control agents in SVTs. That is supraventricular tachycardias. This is, as a whole, I've condensed it into a single slide. So if at all you want to take screenshots of this, please do go ahead with it. I'll wait for 10 seconds and then I'll go to the next slide. Okay, fine. So this slide is exclusively for rate control agents. The next one is for rhythm control. So these are the important drugs, the doses, and the contraindications and the precautions that need to be taken. Okay. So the last part of it is one thing which you all need to know. Whenever you have a question that is asked, as much as possible, if there are anything that has relevant trials associated with it, please mention it in the exam. You don't need to write in depth like how they give it as a paper. That is the going in a PICO format, the population, the intervention group, the control group, the outcomes. That much details is not really necessary, but at least you need to know what the study was about. So that will add value because in the exam, for each question, if you keep 18 minutes, out of which 15 minutes is what you can maximum allot. The last 3 minutes is like an emergency period. So within that 15 minutes to cover everything will be difficult. And especially mentioning about trials related to that is all the more difficult. But when you mention about trials, it will definitely add mark value to it. So it's always better to mention about it. But if mentioning it like this in 1 to 2 lines is also fair enough because the exam you already would be stressed. So you will not be able to figure out a lot of things at that point of time. So the important thing I want to emphasize is know about the trial name and what the conclusion was. So at least that will give you some amount of value to your answer. So with regard to atrial fibrillation trials, with regard to rate and rhythm control, the first one is about this drug called dronidaron. All right, there were two trials. One is the Athena trial and the Pallas trial. Athena trial, dronidaron reduced death or cardiovascular admissions in elderly low risk paroxysmal or persistent AF patients. All right. But Pallas trial, it came after Athena, but they showed dronidaron kills high risk AF patients. All right. So even though it is not main recommended or mentioned in any of the guidelines, it needs to be kept in mind that this drug has been used in AF in low risk patient groups. Athena, like Athena had shown dronidaron to be good, whereas in Pallas, it is shown to be bad. All right. The next trial is about lenient versus strict rate control. That is called the race 2 trial. In that, strict control, keeping it less than 80 was no better than keeping it less than 110. That is why you say AF with control ventricular rate and AF with fast ventricular rate. That cutoff number now we keep it at 110. So if it is less than 110, you don't really need to worry much. But if it is more than that, you need to be little uh, aggressive in your treatment. And with regard to rate and rhythm control, this is very, very important. This is the AFFIRM study, which had shown that rate control is non-inferior to rhythm control. And it can be possibly superior in elderly and comorbid patients. So previously, they used to have a notion that rhythm control is best. But then this trial had proved that wrong. You can go with rate control for management of patients with AF. And in subset of patients like elderly and patients with comorbids, it had been found to be superior. So the AFFIRM trial needs to be definitely kept in mind. If you guys prepare notes in under AF when you're preparing, keep these names or trials in a small piece of sheet and please underline AFFIRM trial because it is very important and that was supposed to be one of the landmark trials that had come out in relation to AF. So these for rate and rhythm control, these were the four trials. For ablation in paroxysmal AF, we have something called the APAF trial, whereby patients with the paroxysmal AF who failed antiarrhythmic therapy did well with radio frequency ablation at 1 year. So that was one benefit of radio frequency ablation. Then you have another trial called the thermocool AF trial, whereby ablation for paroxysmal AF in anti-drug therapy failure patients, it was found to be superior, but in 1/3 of patients, there was treatment failure that occurred after 9 months. All right. So in both of them, they found it is superior to drug therapy, but in one of them, at 9 months, there was found to be failure rates. And with regard to anticoagulation, for each of the anticoagulation medications, there had been an important study. For apixaban, you had the Aristotle trial, whereby apixaban was shown to improve mortality, bleeding, and stroke rates. That is, it decreased mortality, bleeding, and stroke rates. Use of aspirin. You had the SPAF trial and the SPAF2 trial. All right. SPAF trial, aspirin or warfarin on its own was found to be superior to placebo. The SPAF2 trial showed aspirin was sufficient in young and healthy, but in elderly patients or high-risk patients, combination with warfarin was necessary. For dabigatran, you had the RELY trial, RELY trial, where dose of 150 dabigatran was associated with less stroke than warfarin, but with similar bleeding risk. That is why I mentioned the main dose is what is important. The reduced dose needs to be used only in selected patients. Then coming to rivaroxaban, we have the ROCKET AF trial, whereby rivaroxaban was found to be non-inferior to warfarin in relation to bleeding and stroke. And for warfarin, you have this SPARF3 trial, where they had shown that INR targets between 1.2 to 1.5 versus 2 to 3 in those subset of patients with an INR of 2 to 3 had a decrease in stroke in the high-risk patient groups. All right. So that is why they say whenever you use warfarin, you always try to keep the INR at 2 to 3. So that will help you to reduce the stroke in high-risk cases. So the trial that was responsible for this interpretation and inference was supposed to be the SPARF3 trial. All right. So SPARF1 was aspirin or warfarin versus placebo. Either of them are found. Both of them are found to be superior. SPARF2 was aspirin is sufficient in young and healthy patients, but in high-risk patients, warfarin also needs to be added. SPARF3 was specifically for warfarin in relation to INR targets. They said 1.2 to 1.5 versus 2 to 3. They said that 2 to 3 reduces stroke in high-risk patients. All right. Thank you. So if you have any queries, please put it in the chat box. If some of you are going to see this video on the later phase, if you have any queries, please be free to let us know in the WhatsApp group. So I think Niharika madam has joined. Good evening, madam.
Thank you, Srihari.
I'll just stop sharing.
Sure.
It's all yours, madam.
Thank you, Srihari. Thank you. I hope my screen is visible.
Yes, ma'am.
Okay, thank you. So, good evening, all. So, welcome to the top theory online course. So today is the first day we have started it finally. So I hope this would be a very useful course for you people. And my suggestion is that once you get the recorded session, please go through it once. If you have the habit of writing the notes, please write it down or read it and try to complete the portions in the week that is there. Okay, otherwise, if you just keep on for the next 2 or 3 weeks, then you would not be able to complete it because you need to revise these topics. These are all very, very important topics, exam topics. Okay, so please go through them as soon as possible as you get the recorded sessions. Okay, so today I'll be discussing about acute aortic dissection. This is one of the potential theory question. So we'll discuss this topic in the headlines of introduction. What are the risk factors? Classification of acute aortic dissection, how to diagnose it, and what is the management. Now, coming to the introduction, so what is acute aortic dissection? It is nothing but a tear in the intimal lining of the aorta, which extends into the media of the wall. So, what happens when this tear occurs in the intima? The blood flows through this tear, leading to the formation of a false passage, which is bordered by the inner and the outer layers of the media. So if you see here, this is a healthy vessel. So this is the lumen. So this light pink color is the intima. Then comes your media, and the dark pink one is the adventitia. So what happens is, in stage 1, there will be a rupture in the intimal layer. And when this rupture happens, the blood flows from the intimal layer into the media, forming or leading to the dissection of the media. Okay, and in stage 3, as this blood goes on accumulating, there would be a pressure increase, and at a point it leads to the rupture of the vessel. So these are the 3 stages of aortic dissection. So you should know the definition and the 3 stages of the aortic dissection. Now coming to the important causes or the risk factors for the dissection. So this can be divided as a subheadings. So first would be your connective tissue disorders, including your Marfan syndrome and Ehlers-Danlos syndrome. Use of cocaine, or it could be iatrogenic, like cardiac catheterization, post-cardiac surgery, or the use of IAPP. In some cases of pregnancy, normal pregnancy can also lead to aortic dissection. Some structural defects like bicuspid aortic valve, coarctation of aorta, or if there is an annulo-aortic ectasia, it may lead to aortic dissection. As we all know, syphilis is also one of the cause for aortic dissection. Any trauma or vasculitis, especially the giant cell arteritis or Tachyarrhythmias, can lead to aortic dissection. And some inheritable conditions like adult polycystic kidney disease, which usually causes abdominal aortic dissections, osteogenesis imperfecta, homocystinuria, familial hypercholesterolemia, and Turner syndrome all can lead to aortic dissections. Now coming to the important thing, the classification, because according to classification only, the management also varies. So classification, it's basically broadly classified into 2 categories. One is classification by the location and classification by the chronicity. So first we'll go for classification by location. So you have 2 important classifications in this. One is the DBK's classification, and the second one is the Stanford classification. So this DBK's classification is being divided into type 1, type 2, type 3. So what is type 1 of DBK? So basically the dissection starts from the ascending aorta. Okay, and it can progress to the arch of aorta and even the descending aorta, the pink color one. Okay, so usually starts from the ascending aorta and can progress to any of the part of the aorta. That is type 1. So what is type 2? It arises from the ascending aorta and it is limited to the ascending aorta. So it will not reach to the arch of aorta nor the descending aorta. Whereas in type 3, it usually arises from the descending aorta distal to the subclavian and then involving the entire descending aorta, or in some cases even the abdominal aorta also. That is the type 3. Now Stanford has divided into 2, type A and type B. So type A includes all which involves the ascending aorta, and type B is only the descending aorta. So if you see here, type A is basically the type 1 and type 2 of DBKs, which usually involves the ascending aorta. And if it involves only the descending aorta and no ascending aorta, it is the type B of Stanford's classification. Okay. So as I told, DBK type 1, type 2, type 3. In type 3, again, we have two, 3A and 3B. 3A is basically limited to the descending thoracic aorta, and 3B extends below the diaphragm, involving the abdominal aorta also. Stanford type A, type B. Okay. Now, as I told, the second classification is by chronicity. So whether it is acute, subacute, or it is chronic. So acute is the dissection occurs within 14 days of onset of pain. That is the acute aortic dissection. Second, subacute dissection is between 15 to 90 days of onset of pain, and the chronic is more than 90 days from the onset of pain. Okay, so this is the classification of the aortic dissection. So by the location, you have the DB case and the Stanford, and by chronicity, you have acute, subacute, and chronic. Now next come how to diagnose. So diagnosis basically contains the clinical features and the investigations. So coming to the clinical features. So clinical features, so we'll divide it into Stanford type A and Stanford type B. So Stanford type A, as I told, it involves the ascending aorta. So when it involves the ascending aorta, the most common clinical symptom would be severe chest pain. Okay. Okay. So since it involves the ascending aorta, usually the upper part of the body is involved. So patient can experience syncope. There could be aortic insufficiency. There could be pulse differential. And two major symptoms would be, one is the cardiac and the neurological features. In cardiac, they are more prone to myocardial ischemia if the coronaries are directly involved in the dissection. And second one is the neurological symptoms and signs. As I told, there could be syncope, there could be stroke, there could be coma, anything can happen. Okay. Stanford type B is basically the descending aorta. So usually it involves the below the diaphragm. What are the organs involved? So all the symptoms related to that. Okay, so as I told, in Stanford type A, it is chest pain. Whereas in Stanford type B, it could be either severe chest pain or severe back pain, or it could be a radiating pain. Means it starts from the chest pain and it radiates to the back. Okay, there could be a distal pulse differentiation. And the important things are renal insufficiency and limb pain or claudication. Okay, so these are the clinical features seen in Stanford type B. So why is the diagnosis important? Because treatment is time crucial. Okay, because here, after the symptom onset, the mortality increases by 1 to 2% per hour after the symptom onset. So patients may die very fast. So they tell that the mortality, okay, 20% of patients, they die before reaching hospital, and around 50% of patients may die before reaching a specialist center. So diagnosis and rapid management is very important in aortic dissection patients. So what are the important investigations that we perform in these patients? So the best or the first line imaging would be the CT of the chest and the abdomen, okay, to even rule out if there is an abdominal aortic dissection. So what information do you get from doing a CT? So you will know the type, okay, whether it is type A or type B, where is the exact position of the dissection, what is the size of the dissection, and also it helps to identify any other cause for the symptoms or to rule out any other differential diagnosis. Okay, that is the use of CT in acute aortic dissection. So usually we use a contrast enhanced CT angiography. And as I told, the scan should extend from the chest down to the pelvis. So you have to do a CT chest and the CT abdomen. And what do you see in that? You see something known as tennis ball sign, which is nothing but a visible dissection flap. Now, if you see in this image, so this is the dissection. This is the tennis ball sign. Okay. So this is the ascending aorta, whereas this is the descending aorta where you're seeing the flap here. Okay, so this is the flap here. Okay, so this is the one which you see in contrast CT. The second, the most important one which we can do on the bedside is the point of care ultrasound. So we can use either the TTE or you can use the transesophageal echocardiography. So as we know, the advantages of the transthoracic is it is less invasive and it is more readily available. And what is the role of transesophageal echo? Usually used in intraoperative period when you're operating the aneurysm. So you can use a transesophageal echocardiography, or in some cases where you're still in confusion, even in ICU patients who have been intubated, you can use the transesophageal echo. So basically, which view that we use to see the dissection is the suprasternal echocardiographic window. Okay, so basically we see the arch of aorta. So what do you see? You can see the aortic valve, aortic root, ascending aorta, and even the pericardium, because when it ruptures, you can even see the pericardial effusion here or pericardial tamponade. So this is the point of care ultrasound. So if you see in this, so this is the aorta. You can see there is dilated aortic root with some flap here. Okay. And when you put a color Doppler, you can see there is a severe AR which is happening here. Okay. So if they ask you what are the echocardiographic findings in aortic dissection, so you can see a dissection flap. You can see the aortic valve disruption in the form of aortic regurgitation. You can see pericardial fluid in the form of pericardial effusion or tamponade. There could be aortic rule dilatation. And if the coronaries are affected, you can even see the regional wall motion abnormalities. So these are the findings which you can see in a transthoracic echocardiography in case of aortic dissection. Okay. The next one is, as I told, if you're doing TTE to rule out thoracic aneurysm, aortic aneurysm, you have to do abdominal aorta scan to rule out the abdominal aortic aneurysm. Okay, so you have to examine the aorta both in transverse as well as longitudinal section. And what do you see? You see either a flap or a thin membrane which is fluttering within the vessel. And when you put a color flow Doppler, you can see some flow through the false lumen. And when you combine both the TTE and the abdominal aorta scanning, then the sensitivity increases to around 67 to 80%, and the specificity for this combination ultrasound is around 99 to 100%. Okay. Next would be MRI. It has a very good sensitivity and specificity, but a lot of limitations. Patient is hemodynamically unstable, so you can't shift the patient for a longer time because it has a prolonged scan time. Sometimes availability would be a problem in some institutions. Okay, so very rarely done test is the MRI. So simple tests. Can you identify from an ECG and chest X-ray the acute aortic dissections? Yes, we can identify. So around 70% of patients with type A aortic acute aortic dissections, they have some abnormal ECGs. So what are those abnormal ECGs? The most common is the ST depression and the T wave changes. But if your coronaries are involved directly in the dissection, then ST elevation is also seen. Okay. And if you see the presence of ECG changes, they're usually associated with increased incidence of shock and cardiac tamponade. So you'd be very careful. Do an ultrasound immediately or the echo immediately to see if there is a tamponade. Okay. Then chest X-ray. Yes, especially if it is a type A aortic dissection, you can see there would be a widened mediastinum, and we always see this aortic contour, right? So this aortic, there could be an irregular aortic contour, and if there is a rupture, you can even see sometimes the hemothorax. Okay. Coming to the biomarkers, a lot of meta-analysis has been conducted, and they showed that D-dimer levels of more than or equal to 500 nanogram per ml is associated with around 97% sensitivity and 56% specificity in diagnosing the acute aortic dissections. So these are the important investigations. You can even mention the normal basic investigations, but I've only just mentioned about the investigations which are relevant to the acute aortic dissection. Now, the next important thing is about the management. So the initial management, patient would be usually hemodynamically unstable. So ABC is very important. So resuscitation and stabilization of the patient, Wilson deciding and preparing for definitive intervention is very important in this case. Everything should go on simultaneously. And our main thing is to reduce. What is the goal in the treatment of the acute aortic dissection? It is to reduce the shear forces being placed on the aorta, Wilson ensuring sufficient organ perfusion. What does this mean? We need to maintain the BP and heart rate in such a way that it should neither cause insufficient organ perfusion nor it may lead to increased area of dissection. So you have to maintain your BP and heart rate adequately. That is the major important thing that you do in cases of acute aortic dissection. So now before going to the proper thing, we'll just go through this flow chart. So yes, you have a patient has presented to you with symptoms of aortic dissection. So you have suspected an aortic dissection. So what you do first is you have to do an initial stabilization like ABC, wide bore IV access, invasive BP monitoring and tight BP control. And importantly, there is a severe pain with aortic dissection. So you have to ensure adequate analgesia. If you have the operating or any other management team in your hospital, you can go through the further diagnostic imaging. Otherwise, please try to transfer the patient as soon as possible. That is known as scoop and run. So it should be very fast enough to transfer this patient. And in the initial stabilization part, what should be the targets that you need to achieve? Okay, you have to maintain your SpO2 above 95%. Maintain your hemoglobin around 12 gram per dl. The systolic, this is very, very important. The systolic BP should be between 100 to 120 and your heart rate should be 60 to 80 in order to reduce the shear stress on the aorta. Okay, so these are the targets which you have to maintain by initial stabilization. So once you have stabilized the patient, then try doing the diagnostic imaging, whichever is possible. If the patient is stable, try to do the CT as soon as possible. If not, try to do a bedside TE or the transesophageal echocardiography. So while doing all these things, please discuss with the surgical team whether this patient requires an intervention or whether this patient requires a local management versus transfer. Everything has to be discussed with them. And now coming to the type of dissection which is present. So whether it is a type A dissection or type B dissection. So type A is basically involving the ascending aorta. If that is involving an ascending aorta, the only option that is available other than the medical management is your surgical intervention. That too, an open surgical repair is required. But if it is a type B dissection, then you have to see whether it is an uncomplicated dissection or a complicated dissection. If it is an uncomplicated dissection, type B, just medical management is sufficient. But if it is a complicated one, now what is a complicated type B dissection? If there is a persistent refractory pain, if there is a malperfusion, that is involvement of any other organ like AKI or limb ischemia, or if there is a rupture or leak, and if there is a rapid expansion of the false lumen, then you have to do a surgical intervention. That too, an endovascular repair is required in this. Okay, so if they ask the management in your exam, please write this flow chart. Okay, so time also will be saved if you write it in a flow chart manner. So as I told, blood pressure management. So tight blood pressure control and reduction of the rate of pressure rise during systole is vital to reduce the chances of dissection propagating further. Now, as I told, I was mentioning about this shear force. So this is basically defined as the change in pressure over time, which is nothing but the dP by dt. And our goal, as I told, is to maintain this dP by dt as less as possible so that the dissection will not be propagated further. Okay. So what type of drugs can be used to control the BP? In the absence of aortic regurgitation, the first line antihypertensive which is used is a beta blocker. Okay, so you do an echo, there is no aortic regurgitation, give a beta blocker. As I told, what should be your target? Heart rate should be 60 to 80 per minute and systolic BP 100 to 120 mmHg. So please, you have to mention this, put it in a box in your exam, and if they ask this question, so highlight the important points. Okay, so please highlight this heart rate and the systolic blood pressure. And what are the beta blockers that can be used in case of acute aortic dissection? You can use either esmolol, labetalol, or metoprolol. So most commonly we use the esmolol and the labetalol. So doses, please go through it. So esmolol, the loading dose would be 200 microgram per kg, followed by an infusion of around 50 microgram per kg per minute. Okay, further loading doses and increased maintenance dose may be required if the BP is not controlled. Labetalol, so the dose would be around 0.25 mg per kg, and further boluses you can give at 10 minutes interval until the blood pressure is adequately controlled. Once the appropriate blood pressure is controlled, you can start an infusion also. And metoprolol, you can give a boluses of around 5 mg every 5 minutes, and the maximum dose would be 15 mg. So these are the beta blockers which are used to control both the heart rate as well as the BP. Suppose if the patient is intolerant to beta blocker or if there is an aortic regurgitation, then the next line of drug would be the non-dihydropyridine calcium channel blockers, that is the diltiazem or verapamil. Suppose if we are not able to control with these two medications, these two group of drugs, then the final drugs would be your vasodilators, that are the sodium nitroprusside and the glycerin trinitrate. But the disadvantages of using these vasodilators are it causes reflex tachycardia. So when this tachycardia is present, then your shear stress on the aorta increases. So there would be dissection, or there could be even the myocardial ischemia. Okay, so you should be you should monitor appropriately by using your vasodilators. So this is one of the easy algorithm for the blood pressure control. So as I told, first would be the rate of pressure control. So the most common drugs would be the beta blockers. Or if you're not tolerant or the patient has aortic regurgitation, then use a calcium channel blockers. Try to titrate the heart rate to less than 60 and the systolic blood pressure less than 120. Along with this, important thing to control the blood pressure is your pain management. Try to give the adequate pain control. The most commonly used medications are the opioids. So even with these two measures, if you're not able to control the BP, your systolic BP still remains more than 120. As I told, the final thing would be using an intravenous vasodilators. Okay. So this is about the BP control or the medical management which is required both in type A as well as in type B. Now coming to each of it. Now coming to the type A aortic dissection. As I told, surgical treatment is the treatment of choice in these patients. So surgery is the standard treatment of acute type A aortic dissections, and it should be undertaken as soon as possible after diagnosis. Okay, so the basic principles would be, you have to reset the primary tear, establish the blood flow in the true lumen, and replace the dissected intrapericardial aorta. The surgical principles actually are not necessary for you to write in the exam, but just to have a knowledge how to actually, what important things that you should know is, 3 important things are necessary in case of a while operating the type A aortic dissection. One is, all these patients, they undergo a cardiopulmonary bypass. Okay. Second, very important surgical principle is, you have to maintain or have to protect your brain. Okay, so cerebral protection is one of the important principle while operating these patients. Okay, so most of the aortic surgeries or the thoracic surgeries, we usually do a cross clamping of the aorta. But in this case, you should not do a cross clamping of aorta, because already in dissection, especially this ascending dissection, blood flow to the brain is already hampered. Okay. So if you do a cross clamping, further blood flow would be reduced and may lead to stroke. So the important principle is you should not use a cross clamp for aorta in these surgeries. Second, you can also do cerebral protection with the help of deep hypothermic circulatory arrest. And third, something known as antegrade cerebral perfusion can also be done. Need not to know in detail, just some surgical principles which are required. I'm just want to highlight. And the third one is these patients, you need to insert a spinal drain in order to basically maintain a proper spinal pressures to prevent paraplegia. Okay, so these are the three important surgical principles that are necessary while operating the acute aortic type A dissections. So one is CPP will be initiated, second cerebral protection is important, and a spinal drain has to be inserted. Okay. Now, what are the early postoperative complications which usually occur with these surgeries? One is multiple organ dysfunction. Okay, so as I told, these patients may have a postoperative dialysis or AKI. Patients may experience stroke. There could be coagulopathy in the form of bleeding because you are using hypothermia here and there is a prolonged, if you are using a prolonged CPB, and if you're not going to maintain your spinal pressures properly, you may, or it may lead to spinal cord ischemia. So these are the most important post-operative complications. It's a very dangerous surgery, not a simple surgery at all. So as I told, they might ask a short note on post-operative spinal cord perfusion optimization in these patients. Okay, so as I told, one of the important complications is spinal cord ischemia. So post-operative management should basically include neurophysiological and intracranial or intrathecal pressure, ICP monitoring, and CSF drainage has to be done for up to 72 hours. So if any neurological deficit is identified, measures should be instigated to optimize the spinal cord perfusion and thus negate its progression. So how to prevent this spinal cord ischemia? So there is something known as the COPS protocol. So what is this COPS protocol? One is C stands for CSF drain status, O stands for oxygen delivery, and PS stands for patient status. So as I told you, put a spinal drain, right? So post-operatively, you need to maintain this patient flat and you have to measure the spinal cord drain pressures, and that has to be kept less than 5 mmHg, and this drain is to be kept for minimal of 7 days. So there's chances of infection also with this. Okay, so this is one of the way to prevent the spinal cord ischemia. Okay, and if you find any malfunction, if the drain pressures are very high, then please, you need to replace the drain as soon as possible. Second, O stands for oxygen delivery. Okay, so you have to maintain the saturations between 94 to 98. Your hemoglobin, please maintain your hemoglobin of more than 10, and your cardiac index should be more than 2.5 to maintain the spinal cord perfusion. Okay, coming to the PS, the patient status, your systolic blood pressure should be more than 180 post-surgery. So pre-surgery, it should be between 100 to 120, whereas post-surgery, in order to maintain the spinal cord perfusion, you should maintain the systolic BP of more than 130. The spinal cord perfusion pressures, okay, should be maintained of more than 120, and you have to see the cognitive status of the patient. So assess his GCS as soon as possible. Okay, don't continuously keep on sedation. Try to assess the cognitive status of the patient. Okay, this is about the COPS protocol in order to prevent the spinal cord ischemia post-operatively. Done? So this is about the type A aortic dissection. Now coming to the type B aortic dissections, where I told most of the patients, nearly 90% of patients can be managed medically by the control of blood pressure and the analgesia. And the surgery is only required in the complicated type B dissections. Now, as I previously mentioned, what are these type B complicated things? One is persistent refractory pain. If there is a rupture or leak, if there is a rapid aortic expansion, and if there is a malperfusion. So in such cases, as I told, endovascular surgeries. And what is that surgery named as? It is the TEVAR, the thoracic endovascular aortic repair. So in cases of complicated type B aortic dissections, you have to do the TVAR. Okay. So this is one of the flow chart which is giving the management of acute type B aortic dissection. So complicated, you have to see whether it is suitable, if there is a suitable proximal and distal seal zone is present or not. If there is a distal, a proximal and distal seal zone is good, then you do a TVAR. If no, then you have to do an open surgical repair. This is very, very rarely required. Okay. And in uncomplicated dissections, medical management is more than enough. Okay. So this is just one diagram of thoracic endovascular aortic repair. Basically, you use a femoral approach because it's a descending aortic aneurysm, and you put a stent here, distal to the aneurysmal site. Now, as a common, what should be the post-operative care that should be given to the aortic dissection patients? One is importantly analgesia, because you need to ensure that the patient can mobilize and ventilate adequately. Usually multimodal analgesia is required, and physiotherapy in order to prevent the post-operative pulmonary complications. And the important thing is rehabilitation in these patients. So early mobilization, daily orientation, spontaneous awakening and breathing trials, sleep promotion, and basically daily assessment of delirium has to be done in these patients. Okay, so coming to the conclusions, acute dissection, it represents a condition with significant mortality and morbidity. Hence, rapid diagnosis and management is very, very important. And the most important medical management which is in our hands is the control of the blood pressure and the heart rate and the adequate control of the pain. And in type A dissections, open surgery, type B, uncomplicated medical management, complicated TVAR has to be done. Okay. So these are the references. Thank you. So this completes the first day topics. So tomorrow we will be coming with some other new topics. So if you are free enough, please join in the online class. So if you have any doubts, please put it in the chat box. And if you have any other doubts also in a specific topic, if I think you will be having our numbers also, they'll be providing you the numbers. You can message us at any time, personal messages. Don't worry, whenever we are free, we are going to answer whatever you want. Okay, so we'll reply you. Okay, so if you have any doubts, you can even message us personally also. Okay, thank you.
Thank you, ma'am.